Without further ado, please give a very warm welcome to Dr. Aseem Malhotra.
Wow, that's the best reception I think I've ever received. So thank you everybody for coming tonight. Just a bit about me that people don't know my background. So I'm a cardiologist. I've been a qualified doctor now for well over 20 years. The overwhelming majority of that time has been working the NHS. The reason I started as a campaigner and activist well over 10 years ago was because I saw that the NHS was going in the wrong direction. And Aneurin Bevan, the MP that essentially was the brainchild, the Labour MP behind the NHS, when it was founded in 1948, wanted to create a healthcare service that was not just free at the point of need and free at the point of use, but what many people have forgotten is he wanted to make sure it was the best possible healthcare that people can achieve. In my lecture, I'm going to try and get to the roots of the problem. Why are we not universalizing the best care for all? And of course, the COVID vaccine issue is front and center of the talk and really a symptom of our system failure. But before I start that, there's a couple of psychological concepts I want people to try and appreciate, to try and understand why there's so much division and different points of view and very passionate different points of view around this issue about COVID, the pandemic, and even the COVID vaccines. And the first is one of fear. Fear as a psychological phenomenon, which we all experience in different circumstances, it inhibits our ability to think critically. And it's really important to understand that because that's still an ongoing problem and it's an issue for many people. And we all had, many of us, certainly at the beginning of the pandemic, were gripped by fear that we've never experienced in our lifetime with what was happening. The second concept I want people to understand is one of willful blindness. So this is when people turn a blind eye to the truth in order to feel safe, to avoid conflict, to reduce anxiety, and to protect prestige, or in some cases, precious, fragile egos. But it's important that we start from that understanding so that we can move forward in the right way, so that we disseminate the right information in the right way. And I think we have to do this assertively, but we also have to do it with compassion for people who are not as enlightened as many of us are at the moment on these particular issues. So what's worse than ignorance? The late, great Stephen Hawking told us, the illusion of knowledge. Let's try also and understand what we mean when we talk about health. And I actually, listen, I think the WHO don't do everything right, but certainly their definition of health, I think, is spot on, which is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And when we talk about public health, it's a science and art of promoting health, preventing disease, and prolonging life through organized efforts of society. Another definition which I like is that it's a science and art of organized societal efforts to ensure and create the conditions for the highest possible level of health and well-being of the population consistent with the values of social justice and human rights. So it's important to have these definitions, understand them properly, and then try and figure out, are we actually doing the best for public health? And if we're not, why are we not doing that? So where are we in terms of the NHS and our health in the UK? It's not great. So life expectancy has now stalled since 2010. And in fact, in many areas of the country, chronic disease is getting worse. So people are living longer in poor health. That's a really sad indictment, if you like, on the overall healthcare system. And I think we all have a role to play in that, including the medical profession. You know, one of the things I try and, information I try and propagate to my colleagues, you know, in a constructive way, is saying, well, just stop it for a second and think, if we as doctors were doing everything correct, Why is the health of our population getting worse? Have we got a role to play in that? Just ask yourself that question. So more recently, I've published a lot over the years and as an activist, coming from the perspective as a cardiologist to try and figure out why we're not tackling heart disease in the best way we can, despite so-called modern science and the best possible information we think we have. You know, heart disease is still the biggest killer in the Western world. It's still the #1 cause of premature death in European men. So clearly there's something that we've done wrong on that front. And for me, that's really what's driven most of my scientific research work. More recently, of course, my latest publication, which got a lot of attention, certainly on social media and certainly international media, not so much UK media yet, was published in the Journal of Insulin Resistance. And the talk that I'm going to, over the next hour or so, a lot of what I'm going to discuss is in those papers, and they're free and open access. And I deliberately chose this journal for 2 reasons to publish it. One was, it was the only journal that was going to allow me to write 10,000 words. Medical journals don't normally allow that, because I felt that I needed to write that much for people to understand the roots of the problem. But also, it's a journal that doesn't take money from the pharmaceutical industry. And that was also important. And I said to the editor, it has to be... And it has to be free and open access for people. We should not be commodifying this knowledge, which is so important. There's been obviously trolling on social media. Dr. Malhotra edited his own journal. I have a very honorary, cursory, kind of distant role as an advisor to that journal, but the editor has got very high integrity, and in fact, he went through an external peer review. And of all the medical journal articles I've published over the years in the BMJ and many other prestigious journals, this was the most rigorously peer-reviewed article I've ever written. It took several months from when I submitted it to actually finally being accepted, because the peer review went back and forth. Okay, what's going on with medicine? What's wrong with it? So very simple, analytical, and elegant framework, which I like to talk about. One of the most important slides of my talk, I think, so feel free to take a screenshot of it if you haven't seen it already. It's called the evidence-based medicine triad. So in order to improve patient outcomes, for us as patients, we want, as doctors, we are there to relieve suffering, treat illness, manage risks. And the concept, which I think is very elegant and quite straightforward, is we use our clinical expertise, our experience, and with time, clinical intuition with experience, the best available evidence, and last but not least, probably the most important, is to take into consideration patient values and preferences. So any deviation on those components, we are not going to get the best outcomes for patients, and at worst, we're going to do harm. And I think to understand where we are in terms of medicine, understanding this concept will help us solve these problems as we move forward. So what's wrong with the best available evidence? Well, unfortunately, evidence-based medicine has been hijacked by Big Pharma. It's become an illusion. And because of that reason, we are not able, patients are often doctors are getting information to make clinical decisions on biased and commercially corrupted information. And again, it doesn't take a rocket scientist to figure out if that's happening, you're not going to get the best outcome for patients. So what are these factors that are driving inefficient healthcare? So I talk about this pandemic of misinformed doctors and unwittingly harmed and misinformed patients, and it's because of biased funding of research that's funded because it's going to be profitable, not because it's beneficial to patients, biased reporting in medical journals, biased patient pamphlets, biased reporting in the media, big issue, we'll talk about that, commercial conflicts of interest, defensive medicine, and last but not least, medical curricula that fail to teach doctors how to comprehend and then communicate health statistics. So there will be a little bit of statistics in my talk, but I promise you it is simple. It is not rocket science at all. But we're not doing things properly. Now, a man who I describe probably, and I think rightfully so, as the Stephen Hawking of medicine is John Ioannidis, professor of medicine at Stanford. And John Ioannidis is the most cited medical researcher in the world. And a few years ago, he wrote this great paper called How to Survive the Medical Misinformation Mess, to try and understand why is there so much medical misinformation out there. And what he says is this. He says, much published research is not reliable, offers no benefit to patients, or is not useful to decision makers. Most healthcare professionals are not aware of this problem. Don't presume your doctors understand or know about this issue. They then also lack the necessary skills to evaluate the reliability of research and then translate it into decision-making for patients and for families. And I can tell you in my career, certainly over the last 10 years, through various work with medical royal colleges, as a trustee of the King's Fund, speaking to very senior scientists, and John Ioannidis, and I agree with him from my own experience, he says ignorance of this problem, even at the highest levels of academic and clinical leadership, is profound. Now, we'll talk about the vaccine shortly, but very briefly on this note, I got very heavily involved in campaigning for ending the NHS vaccine mandate. And in that process, one of the people, and I have a big network of people in medical leadership positions, was a chair of the BMA. And when Sajid Javid came out and said we're going to, mandate the mandate the COVID vaccine for NHS staff, I thought there's something really odd going on here. By that stage, I'd already realized there was an issue with the vaccine. I said, this can't happen, this is not right. So I did everything I could and campaigned on it, and I'll come on to that a little bit later. But the conversation I had over 2 hours with the chair of the BMA, and he listened very intently, and I walked him through the data. This is well before I published this paper. He said to me, Aseem, he said, from all the people I've spoken to in medical leadership positions, and he brought into the conversation the chief medical officer in this as well. He says, I don't think anybody has critically appraised the data as well as you have. Most of these people are getting their information on the vaccine from the BBC. Okay? So just understand, don't presume knowledge at the very highest levels of clinical leadership. What else does John Ioannidis say? Well, he published this paper. It's one of the most cited papers in the history of medicine, published in PLOS One. And he says, and this paper actually is titled, Why Most Published Research Findings Are False. Okay, that's not great, is it? We could do better. But he says this, the greater the financial and other interests in a scientific field, the less likely the research findings are to be true. Now, does that ring any bells? Yeah, does that ring any bells? Okay, so let's try and understand these structural drivers behind all of this. Well, the first thing that's really important to understand, and I spoke in the European Parliament a few years ago about this, is that drug companies and medical device companies have a financial obligation to produce profit for their shareholders. They do not have any legal requirement to give you the best treatment, although most of us would like to, or believe this to be the case. But the real scandals are these, and Peter Wilmshurst, a cardiologist in the Center of Evidence-Based Medicine, points this out in a talk he gives in 2014. And he says the real scandals are these. He says regulators fail to prevent misconduct by industry, and that doctors, institutions, and medical journals who have responsibilities to patients and scientific integrity collude with industry for financial gain. And once I'd acknowledged this properly, I went and spoke in the European Parliament, and I said, because of all of this misinformation coming from pharma that drives our clinical decision-making, honest doctors can no longer practice honest medicine. That is not a good state of affairs to be in. So what can we say about drug companies in terms of, over the years, in terms of their corporate crimes, if you like? Well, Peter Gosha, the co-founder of the Cochrane collaboration, the prestigious Cochrane collaboration, he's campaigned and written about this extensively. And he points out a number of things. One of his analyses suggests that the third most common cause of death now globally, after heart disease and cancer, is prescribed medications. Side effects from, and he said most of these are preventable, right? And the reason for that is that through the information that comes from drug companies, essentially the results of clinical trials exaggerate the benefits and the safety of the drugs. Okay? And the other thing he talks about is the fact that there is a huge history, documented history going back, even in recent years, of corporate crime and fraud. So between 2009 and 2014, most of the top 10 drug companies committed fraud that totaled around $14 billion for hiding data on harms, illegal marketing of drugs. And he points out that actually when all of these companies, big companies, committed these frauds, they paid fines that were minuscule in comparison to the profit that they made. And nobody got fired, and the system just continues to do the same thing. Nothing has changed to stop them committing these crimes again. And he said, actually, it's time to introduce tougher sanctions as the number of crimes, not the detection rate, seems to be increasing. Fines need to be so large that companies risk going bankrupt. Top executives should be held personally accountable so that they would need to think of the risk of imprisonment when they consider performing or acquiescing in these crimes. Now, does this mean everything that the drug companies do is bad? No, absolutely doesn't. And of course, you know, when one looks at, there are many life-saving and important medications that are important, but many of these medications are being overused. But let's just take a step back and think, hold on a minute. Okay, well, people may be playing devil's advocate saying, hold on a minute, aren't drug companies responsible for extending people's lifespans, improving quality of life? Yes, they have absolutely had that role. But interestingly, one of the myths out there is the perception of what modern medicine has done in terms of our longevity. So if you look at research looking at what contribution has modern medicine has played a role in our extension of life expectancy in the last 200 years, for example, 150 years to 200 years, we've added around 40 years to average life expectancy. In 1850, average person lived to 40. Now they're living to about 80. So how much has modern medicine played a role in that? And when they asked public health students, interestingly, people who are well educated, on a survey, most of them thought that 32 of those 40 years of our increase in lifespan had happened because of modern medicine, when nothing could be further from the truth. It's about 3.5 to 5 years. Now, most of that low-hanging fruit actually happened towards the end of the 20th century. A lot of those medications have still been really beneficial, where it's managing heart disease or insulin for type 1 diabetes, for example, or many traditional vaccinations, that happened towards really the end of the 20th century. And you've seen the stalling in life expectancy in the last 10 years. So modern medicine seems to, even from that perspective, seems to be very limited. But what is the overall net effect of the drug industry on society? Well, this is some data looking at drugs that were approved by the regulator in France between 2000 and 2011. And what they found of the almost 1,000 drugs that were approved, most of those drugs were no added benefit over previous drugs, right? Essentially copies of old ones. So drug companies are essentially patenting these new molecular entities that are just changing molecules around a little bit on a previous drug, making loads of money, and then the cycle continues. But what they also found is there were more drugs, about 15.6% of drugs that were approved by the regulator in France, that were later found to cause more harm than good. And in terms of therapeutic interventions that were better than previous drugs, it was about 8%. So double the amount of drugs that were approved by the regulator were found to be more harmful than beneficial to society. So what does that tell you? I think the evidence is pretty unequivocal. The overall net effect of the drug companies, of pharmaceutical industry on society in the last 2 decades has been a negative one. I don't think that anyone can argue with that. That's not just in France. We know that in the same sort of information is there in America. Only 11% of 667 drugs approved by the FDA between 2000 and 2008 were actually truly innovative. Most of them are copies of old. And one of the reasons for that is the drug companies, because of the system failure that we're in, the drug companies actually spend almost 20 times more on marketing than they do on researching new molecular entities, basic science research. The former editor of the New England Journal of Medicine, the highest impact medical journal in the world, Marcia Angel, says, "It is no longer possible to trust much of the clinical research that is published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine." She's not alone. Richard Horton, the editor of The Lancet. In fact, I bumped into Richard, I don't know if he's here today, a few days ago actually on the street in Hampstead, and he said he was going to try and come to my talk. And I told him I was going to reference him, and he was smiling. That Richard Horton, in an editorial in 2015, actually said in a meeting that he had, a Chatham House Rules meeting organized by the Wellcome Trust with some of the top scientists in the world, he said in that editorial what he inferred from that discussion was possibly half of the published literature may simply be untrue. The former editor of the BMJ, Richard Smith, again, talks about, in the BMJ a few years ago, about attending a meeting with lots of academics in British institutions. And in that meeting, he asked those people, those academics, he says, how many of you are aware of research misconduct or potential fraud taking place in your departments or have been aware of it in your career? And a third of them put their hand up. He said, how many of you reported it? They all put their hand down. So this is a cultural, and I'll get to the roots of this cultural problem in a while. And then, of course, and this isn't just about money. I think what people need to understand in academic science, a lot of people get their prestige and power from publications. So there is a pressure to publish, and the more publications you churn out, it doesn't matter necessarily how good the publications are, the more likely you are to get promoted. And of course, that does mean that you're more likely to get research funding from the drug companies. But one of the worst egregious crimes I've ever heard of, or certainly that we know of, was a Dutch researcher actually published what was later found to be fraudulent research, lots of publications, on changing guidelines in the European Society of Cardiology guidelines for the use of a beta blocker drug for non-cardiac surgery. And it was eventually found out he committed fraud. And it was estimated that because of his fraud, and he was fired from his job, obviously, it was estimated that because of this fraud, that this particular, just one instance, one particular drug in one indication, it was likely responsible for 800,000 excess patient deaths in Europe over a 10-year period. This should be headline news, right? Shouldn't it? But how many people know about this? Very few, I guess. So I'd become aware of this over certainly 2012. The BMJ launched a Too Much Medicine campaign. As part of my campaigning trying to fix the NHS, I'd understood, of course, we were over-medicating people. We weren't addressing lifestyle as much. And then I had a role. I was invited to be a consultant to the medical Royal Colleges. So they essentially represent every doctor in the UK, the Academy of Medical Royal Colleges. And I helped coordinate a campaign between the BMJ and the medical Royal Colleges called Choosing Wisely. And you know, when you sit around the table with all these Royal College presidents, who many of them are very, they've got very high integrity, they're very smart. It didn't take long for me, certainly, to convince them that the medical Royal Colleges need to launch a campaign to wind back the harms of too much medicine. And this was a paper that was published in 2015. And one of the things that we also noted, if you think about all of the unnecessary treatments going on in the NHS, doctors actually have an ethical responsibility to reduce the waste of this use, of clinical resource, because in a healthcare system with finite resources, one doctor's waste is another patient's delay. The other thing we talked about in the paper was about the misuse of health statistics in informed decision-making. Now, okay, this is probably the most mathematical slide of my talk, so bear with me on this. Okay, I'm going to walk you through it. Again, it's not rocket science, but let's talk about misleading health statistics. So this is really crucial also to understanding the COVID vaccine data. So there are many ways of presenting a benefit. You can use relative risk or absolute risk reduction, or something known as numbers needed to treat. Okay? So if you communicate relative risks as opposed to the absolute risk or the NNT, it can lead lay people and doctors to overestimate the benefit of a medical intervention. So, for example, in high-risk type 2 diabetics, people with type 2 diabetes, the use of a statin drug, atorvastatin in this case, according to the industry-sponsored randomized controlled trial, gives you a 48% relative risk reduction in having a stroke over 4 years. Now, that sounds quite impressive. Imagine the patient coming into the consultation room, they've got type 2 diabetes, I'm the doctor, take this pill, you're 48% less likely to have a stroke. Wow, that sounds pretty impressive. What does it actually mean? Where do we get that information from the trial? It means that instead of 28 in 1,000 people followed up over 4 years having a stroke on the placebo and the dummy pill, and essentially no intervention, no medical drug, right? The drug, people who had the drug, of 1,000 people taking the drug, only 15 people of those 1,000 suffered a stroke. So you reduce the number from 28 to 15 out of 1,000, so that's 13 less people out of 1,000 treated who have a stroke. That's the absolute risk reduction is 1.3%. 13 over 1,000 is 1.3%. Or, in terms of numbers needed to treat, it means you have to treat 77 people to prevent one stroke. So what we should be doing, the way that for an individual to understand that in a way that's considered more transparent and honest, is to say, if you take this pill, and this is what I do, I've been doing this for years in my clinical decision-making, when that information is available, I said, if you take this pill religiously, with all the caveats of industry-sponsored trials, and we'll come on to that later, then there's a 1 in 77 chance it'll prevent you having a stroke. And that's information that doctors should be telling patients. And then we've got problems with mismatched framing in medical journals. So the medical journals will often report the benefits in relative risk, right, the benefit of a drug, but the harm in absolute risks, even though they're exactly the same, which is pretty extraordinary. And it was found that a third of medical journals sampled in the Lancet, the BMJ, and JAMA between 2004 and 2006 used mismatched framing. This is still an ongoing issue. So what ultimately happens is doctors and patients are getting an exaggerated view of the benefit and a minimizing of the harms, when in fact we should be comparing the two exactly in the same way. Now, don't just take my word for it. The sort of one of the leading voices in health literacy, Gerd Gigerenzer, in a World Health Organization bulletin in 2009, And we cite this in our Choosing Wisely paper. He said it is an ethical imperative for every doctor and patient understand the difference between absolute and relative risks to protect patients against unnecessary anxiety and manipulation. So again, remember about evidence-based medicine and the triad. To actually engage in informed consent, or what we call shared decision-making, it must involve transparent communication of risk and benefit of any intervention when that information is available. Otherwise, you're not adhering to the principles of evidence-based medicine. And I'll just tell you briefly, there are 6 criteria for informed decision-making. There's a reason I'm telling you this. I don't want to bore you with too much information here. But of course, in a consultation, you have the description of nature of the decision with the patient, discussion of alternatives. Now, often that doesn't happen, and that's partly because the science medical training hasn't trained doctors to teach them enough about the impact of lifestyle and diet, and I know a lot of people here are big proponents of that, so that's a big problem as well, which we need to overcome. Discussion of risks and benefits are essential in absolute terms. Discussion of uncertainties about evidence. Medicine is not an exact science as well. You know, it's more of an applied science. It's an art. It's not like physics or chemistry. The human body is dynamic. Information constantly changes. You must tell patients that. I tell them that. Uncertainties about the evidence. When I have a conversation with patients, I say, by the way, the evidence I'm giving you is based upon industry-sponsored trials. They hold on to the data. They don't share their data. So this is likely best-case scenario. This should be a genuine, honest, normal conversation that should go on with all the patients. Patients appreciate it because you're being honest. Assessment of the patient's understanding. And finally, elicitation of the patient preferences. Now, they've done studies to see, actually, when you engage in shared decision-making, what happens to patient outcomes? Well, a couple of very interesting points that are made. Patients feel better. They feel they're more empowered with knowledge, okay? They feel more confident about what mattered to them. They've been listened to. There's more informed consent. But interestingly, on average, when you give patients full information about medical and drug, surgical interventions, they actually are less likely to choose them. So there's a massive reduction in medication prescription and surgical operations. So that's great, and it doesn't have a negative effect on patient outcomes. So there's a great low-hanging fruit we could use here, just without even putting more money into the NHS, okay? Just from having a shared decision-making conversation with patients, we will reduce costs and keep quality. In fact, we'll ultimately improve quality of care. And by the way, this is without discussion of other things like lifestyle. So the likelihood is we're missing a big component of improving the NHS just with information we have available on the impact of lifestyle changes, which I'll come on. But how well are we doing in terms of shared decision-making? If you look at the largest study, the systematic review that was done in outpatient settings and assessing doctors, how many of them were adhering to shared decision-making? So in terms of description of nature of the decision, 83%, 14% discussion of alternatives, only 14% of doctors discussed alternatives. Discussion of risks and benefit, only 9%. 91% of doctors were not actually discussing risks and benefits with patients. About uncertainties, only 5%. Assessment of the patient's understanding, 2%. And then elicitation of the patient's preference, only 19%. So no discussion with any of those doctors fulfilled all criteria. So we can do better, okay? We can do better. We've got the evidence to do better. And of course, the barriers of implementing this are many: lack of training, organizational inertia, time constraints, lack of reimbursement. That's probably more in America of an issue where doctors get paid on the amount of tests they order, et cetera, which is completely contrary to the ethics of evidence-based medicine. What we should be doing is patients should be assessing doctors, or there should be some sort of quality criteria on, did you feel this doctor was empathetic but engaged in informed decision-making with you? That's how we should be assessing doctors. That's what we should be doing. Now, again, as an activist, as a campaigner, seeing this injustice and it not making an impact, again, with the medical Royal Colleges, I co-authored a paper 2 years after the BMJ paper with Professor Dame Sue Bailey, who was the chair of the medical Royal Colleges at the time, arguably the most important doctor in the UK, and actually said that if we engage in shared decision-making, we would actually save the NHS billions of pounds and ultimately improve patient outcomes. And I'll tell you briefly, we talked about an amazing case study of a patient I saw a few years ago called Tony Royal. Tony Royal was a former international airline pilot with Virgin Atlantic. He was running marathons. He was following the standard diet, low fat, high carb. He was gaining more and more weight. He unexpectedly suffered a heart attack. Luckily not when he was flying a plane. When he'd landed the plane, he went to his GP and had a heart attack, had a stent. And then he was prescribed a cocktail of medications. He couldn't fly anymore. And Tony was already in what we call metabolic syndrome, which I'll explain to you briefly in a second, but essentially he was overweight and had lots of health markers that were not good in terms of his heart health. And he was prescribed all these medications. He went back to his previous job as teaching maths and physics. He's amazing at statistics and started reading the research himself. Didn't feel great. He was feeling really poorly on all these medications, and he started to stop them himself gradually and then changed his diet. And then he came to see me, and I supported him in his decision-making. And he decided in the end he was going to stop all his pills, and he was feeling amazing. He got all his all his markers better. He reversed what we call his metabolic syndrome. He's off all his pills. I'm still in touch with him. And he's 6 years, I'm just saying what we can achieve, right? 6 years off all his heart medications, having had a heart attack and a heart stent. And he's now still breaking his own records and ultramarathons and Ironman and that kind of thing, which is extraordinary. So it's just to highlight what can be achieved with patients if we engage in shared decision making. Okay, so let's take you on the journey and go back a little bit in time into the coronavirus pandemic, okay? So this is still, I think, gives many people probably what may be best described as PTSD, right? I mean, listen, we were all there, okay? We were all in the middle of it. And I think let's just remind ourselves what was what was the main public health management plan from Boris? Stay at home, protect the NHS, and save lives. But I think there was something missing from that, and very early on in the pandemic, once it became clear there was a clear link between poor diet, in particular obesity, and poor outcomes, once you exclude the elderly, and listen, I'm not in any way undermining the impact of COVID. I'm sure many people here have had relatives, I've had patients, people have been devastated by the impact of COVID, especially in vulnerable people, there's no doubt about it. I've got patients with long COVID, so we know it is a major issue for a lot of people. However, once you exclude age, the most important risk factor for poor COVID outcomes was excess body weight. And we know that 90% of the deaths that have occurred globally have happened in populations where more than 50% of the population was overweight or obese. And of course, UK and USA are up there. But when I noticed this very early on, this link, I thought, hold on a minute. I know that you can reverse those risk factors associated with poor outcomes from COVID very quickly, within a few weeks of just changing diet. Now, of course, a lot of this is environmental, but at the very least, we need to get this information out to the public. And of course, papers started getting published, but it wasn't getting any mainstream media attention, and the link was clear. And essentially, in very simple terms, excess body fat is a substrate for a dysregulated immune system. And this was there in the literature even pre-COVID. We know, for example, people with obesity or type 2 diabetics are more likely to be admitted to hospital with pneumonia, significantly more likely to see their GP with chest infections. So this is something that, hold on a minute, this is actually something we've been missing as well in the part of the narrative of tackling obesity. We probably would reduce the impact of infections and viral infections if we improve people's lifestyles. And then eventually, I kept hammering this. I wrote articles initially. I think it was a Sunday Express. And then I wrote in European Scientist, and it broke the record. I said, and this is very early on. I went on Sky News, and I said, we need to discuss the elephant in the room here, which is that, this is a condition related to excess body fat. And eventually, I was then contacted by one of the editors of The Telegraph, and I wrote a commentary on this that they featured on their front page, saying it's time for an honest conversation about weight. And I drew the research about ultra-processed food, which is more than half of the calories, unfortunately, still in the British diet, and how that ultimately is setting people up for chronic inflammation, which we know is certainly going to be linked to adverse health outcomes from COVID. And I thought, let's use this opportunity to get this into the mainstream media. And it was actually after, it was a couple of months after Boris had been admitted to hospital, as you know, with COVID. And I observed it, and I thought, well, hold on a minute, there's clearly an issue here, because Boris had talked about the fact that I think he was 18 stone and he was very overweight. And I was on BBC News, I was on Good Morning Britain, and I said, from what I've observed, I think there's a strong possibility that the reason that, and he'd come out of hospital then and he was getting better, thankfully. I said it's likely that weight played his role, and then the Times reported on it as it became a big story. And in that process, Matt Hancock, I had an email exchange with Matt Hancock. I'd met him previously. We'll come on to Matt Hancock in a minute. There's something interesting we'll talk about Matt Hancock a little bit later, because we'll have to go back in time a little bit there. But I had an email exchange with Matt Hancock, and he basically asked me to advise him, what should we be doing? And I said, well, listen, you really need to tackle the food industry, because just like, cigarettes and big tobacco, they are hiding data on the fact, or they're suppressing information, doing what they can to suppress information around the fact that ultra-processed foods that they engineer to be addictive, essentially. So anyway, so we go on to the fact that, he then announced, you may remember this, to launch his war on tackling obesity, but unfortunately, none of those evidence-based interventions that have been suggested by the medical Royal Colleges, by Action on Sugar, have been implemented yet, which really addresses tackling the food industry. And then the worst part of all of this as well, which is despite all of this, and I think this is still a cultural problem, I remember in the middle of the pandemic knowing that even high blood glucose was linked to adverse health outcomes from COVID. We were having the promotion, if you like. And listen, I've got nothing against people having a treat, but hospitals shouldn't be promoting and being really chuffed and essentially advertising the fact that we are giving 1,000 free Krispy Kreme donuts to nurses in the middle of the pandemic. I don't think that was very productive, considering what we knew about the influence of COVID. I'll skip forward a little bit, but just to remind ourselves about how these industries behave and what happened before. When Big Tobacco launched their campaign to suppress information on the harmful of cigarettes, they co-opted doctors into this as well. And actually, you can look on YouTube and find this advert that was really put out where doctors were talking about their favorite cigarette were Camels, okay? And we see the same tactics being repeating themselves. What Krispy Kreme are doing, they're using the NHS as a branding opportunity for their really, ultimately what are toxic foods, essentially, addictive toxic foods that should just be treats but not part of the regular diet. Okay, right, vaccines, okay? Let's talk about that. Let's talk about what happened here. So up until, so I was one of the first people, as you may know, I was one of the first people early on to have 2 doses of the Pfizer vaccine. I helped out in a vaccine center, and I was essentially given the leftovers, if you like, at the very beginning when the most vulnerable people were being encouraged to have the vaccine. My father also had the vaccine around the same time. And I went on Good Morning Britain because there was in February 2021 to try and tackle vaccine hesitancy. And the reason I did that, and I tried to do it in the most compassionate way that I could. I wasn't pointing fingers at it. I said, listen, there are rational concerns for vaccine hesitancy. Let's look at what the drug industry have been doing for years. Their business model is essentially being fraud. Right? But at that point, certainly, I did not, and I'll be very honest with you, I did not conceive at all of the possibility, at all, and many doctors are still in the same position, remember that, right, as I was then, that a vaccine could do any significant harm, and certainly not harm to the heart. And one of the first things that happened to me, certainly my father, and I'll mention that briefly later, my father unfortunately suffered a sudden cardiac death in July last year. And that was, again, very shocking and unexpected. His post-mortem findings didn't make sense to me. He had 2 severe narrowings in his arteries. And then over the course of a few weeks, several bits of data started coming in that made me start to think, hold on, there may be a problem here. The first bit of data was an abstract published in Circulation by Stephen Gundry, where he'd actually shown that within just a few weeks of having the mRNA vaccines in his population of patients that he was looking after, there was a massive increase in inflammatory markers that I know, as a cardiologist, are significantly correlated with heart attack risk, okay? And he said that this was, he wrote about this in Circulation. I thought, oh my God, if this is true, it needs replication, needs other data, but it sounds like there's a problem here. At the same time, a whistleblower, a cardiologist from a very prestigious British institution, contacted me and said there are a group of researchers that have accidentally found, through some research using scanning and imaging procedures, inflammation of the coronary arteries with the mRNA vaccine that's there in the vaccinated but not there in unvaccinated. They compared the two. But they then had a meeting and said, guys, we're not going to publish these findings because it may affect our funding from the drug industry. Now, for me, that was unethical, immoral, whatever, and then, again, within a week or two, I also was then alerted to data in Scotland that was showing there was a 25% increase, unexplained, in heart attacks. So there was more than enough data putting it together, and I went to GB News, and this was in October of 2021, and I said, this needs to be investigated. This needs to be investigated. And I also mentioned the fact, listen, I've lost my dad, and in unexpected circumstances. But at that point, it got a lot of attention. And I won't go into the establishment figures behind the scenes that caused me a lot of trouble, but let's just say, and people don't know about this, for a couple of months after this, I was dealing with anonymous complaints from doctors to one very prestigious medical body who then contacted me and basically said that I was essentially bringing that establishment or that into disrepute just because of my GB News interview where I've said there's a possible link here and needs to be investigated. That's all I said, right? And that, of course, could have threatened my license, so I had to deal with that. And I thought, listen, it's clearly not easy just to talk about this openly, even on social media. So what can I do? And what I decided to do then is I said, the only way we can break this, and I'd realized there was a big problem then, is to critically go through this data meticulously in the best way I can, liaise with other people, experts in vaccine development, in immunology, get their opinion, people who are eminent, people who are independent of industry interests, and also make sure that I'm doing things, and then get it published in a medical journal, and then when that was going to happen, I was going to unleash, okay? That took 9 months. It took a long time, but that's the only way I felt, and I tried to keep it going. Okay, so, and by the way, in the middle of this, one of the reasons I was also attacked behind the scenes is because I was very vocal in talking about ending the NHS vaccine mandates. Okay, let's just go through that data in terms of numbers needed to treat. You've now learned about absolute risk reduction. So what did the original trial that lead to the approval of the vaccine tell us? Okay, we were told this 95% relative risk reduction. In reality, if we believe that data to be true, and let's understand one thing, this data is still ultimately the raw data on the patients, tens of thousands of pages, is still being kept secret, right? The regulators have approved it looking at summaries, but we don't know for sure how reliable this really is. But if we take that at face value, that you had to vaccinate, that data suggested you had to vaccinate from the Pfizer trials, and it's similar in other trials, 119 people to prevent one infection, okay? That trial that led to the approval of the vaccine, right, and mandates and coercion, did not show any statistically significant reduction in COVID mortality or all-cause mortality, right? What else was interesting, which I didn't know? I thought, okay, I remember not shortly after having the vaccine, I was sent something, me and my dad was sent something from Public Health England, which was an antibody test, and it tested positive. I thought, great, got antibodies, the vaccine's working. The FDA in May 2021 actually put on their website, you can look at this, and I'll explain why this is. They said they wanted to remind the public and healthcare providers that results from currently authorized SARS-CoV-2 antibody tests should not be used to evaluate a person's level of immunity or protection from COVID-19 at any time, and especially after the person has received a COVID-19 vaccination, right? The reason for this is this. The COVID-19 vaccine, the antibodies don't get into the respiratory mucosa, right? So I think it's very possible, and by the way, that 1 in 119 figure was against the original Wuhan strain, which was much more severe. So could we break down the data and try and figure out the benefits of the vaccine, right? What does the real world data tell us? So I worked with Claire Craig from Hart was excellent in helping me with this. So we looked at UK data, looked at vaccinated people per 100,000 population versus unvaccinated to calculate a numbers needed to treat for benefit, number needed to vaccinate for benefit. Again, likely best case scenario, because they're not correcting for things like people from lower socioeconomic backgrounds often are less likely to be vaccinated, and people with terminal illness, for example, may not be getting vaccinated because they knew they were going to die. So this is still probably a likely best case scenario. And what we found, and I've got this up here, and I'll just give you the summary essentially. So if you look at the Delta variant from last year, which was much more severe, you had to vaccinate 230 people over the age of 80 to prevent one COVID death. Okay, still likely best case scenario. 520 if you age between 70 and 80, and then it got bigger as you as you got younger. For Omicron, from the beginning of this year, Omicron, the circulating variant now, if you were over 80, you had to vaccinate 7,300 people to prevent one COVID death. Now, how many people were told that? They weren't told that. Of course, maybe you didn't have that information, right? And of course, the younger you got, you're talking about tens of thousands of people based upon real-world data of what was actually going on, right? So it's close to non-existent in terms of the actual benefit for mRNA. Now, what does the Stephen Hawking of medicine think? John Ioannidis, and he published this paper in BMJ Evidence Medicine about non-randomized trials, this real-world data, how reliable is it? And basically, he essentially says that this data, these so-called trials that you've heard, these headlines, 20 million people saved from the vaccine. Remember this one from COVID vaccines? He basically said this may be spurious, fake. Okay? And he explains why in detail why this data is not as reliable. And what he says is we need the raw data, and this is before I published my paper. He says we need to discuss this in terms of absolute benefits and harms, which is what I did in my paper. Now, media reporting has a huge influence on our public opinion, and it has a huge influence on doctors. How good is media reporting on health issues? So in the USA, in JAMA, they published this paper a few years ago looking at the reliability of healthcare news stories, and actually on 5 of 10 criteria, they failed to actually report accurately, including things about benefits and harms, about alternatives. So there's a gross misleading information coming from the media, which, by the way, remember, is influencing a lot of doctors in terms of their decision making. And I'll tell you something, and it happened very recently to me. So I've been trying to spread my message on my papers about the vaccine and everything else around evidence-based medicine. And one doctor who was very good, he's a very solid guy, very high integrity, he'd listened to me, he understood it, he's a GP, and then he called me, he said, Aseem, have you seen this? I said, what is it? He said, I want you to look at it, but apparently a lot of these excess heart attacks could be being driven by mild COVID. I said, really? Okay. And this was from the Times. I don't know if people saw this. This was from the Times a couple of weeks ago. Even mild COVID linked to heart disease and strokes. Is this true? No. Okay. Well, you all said no. It could be. It could be true. But no, hold on. It could be true, but is it actually true? Is it based up? What was the paper that this headline was based upon? What did that paper show? Okay? What did that paper show? This is brilliant, right? This isn't even about misleading research or whatever else. The conclusions of the paper published in Heart BMJ said this: individuals hospitalized with COVID-19 have increased risk of cardiovascular events, heart attacks and strokes, right? And the risk of most events is highest in the early post-infection period. Individuals not requiring hospitalization, as in milder COVID, and by the way, this is during most of this was during the earliest ancestral strains, which is more severe, had an increased risk of clots in the lung, not heart attacks. So the conclusions of that paper did not show at all that mild COVID was associated with heart attacks. What else did the paper actually find? It's absolutely fascinating. So on the top left, they had this unexpected finding. In our main analysis, we found an unexpected association of COVID-19 with lower risk of incident of heart attack in the non-hospitalized subset. The paper unexplainedly found if you had mild COVID, you were less likely to have a heart attack. That doesn't fit the Times headline, does it? What else did they write? And this is fascinating. I'm glad they put this in. They've said this. It is possible that risk of cardiovascular events is further reduced with longer follow-up periods. So this is only from March 2020 to March 2021, which basically means that this risk may not be there now. Okay? This risk whatever risk was there may not be there now. And it says there, our analysis does not consider other potential modifying factors such as the impact of vaccination. We know if you have COVID and you're then vaccinated, you are significantly more likely to suffer side effects, right? So this was not looked at. But the headline was, oh, can't be the vaccine, it's mild COVID. Okay, what about the regulators? So, okay, well, all of this, aren't the regulators doing their job properly? Unfortunately, the regulators are conflicted. I'm sure they're well-intentioned, but over time, the regulators have had more and more funding from the drug industry. So we know now that 86% of the funding of the MHRA, and the chair of the BMA, when I gave a talk a few months ago, was gobsmacked. He didn't even know that our regulator gets 86% of their funding from the pharmaceutical industry. He was not aware of it, okay? And Donald Light in this BMJ article basically says that the problem is because of this conflicts, they're not independent, they are selective, they withhold data. Doctors and patients must appreciate how deeply and extensively drug regulators can't be trusted as long as they're captured by industry funding. Okay, what about serious adverse events? So the highest quality level of data is a randomized controlled trial. Reanalysis recently by some of the world's most eminent scientists. When I say eminence, I mean eminence of integrity, people who do not take money from drug industry, okay? These scientists, Kaplan in Stanford, Peter Doshi associated with the BMJ, Joseph Freeman, who I've spoken to, the lead author, they were able to get more information from the FDA and Health Canada's websites, and they found something quite extraordinary. This was ultimately published in peer-reviewed journal Vaccine. This is randomized controlled trial data. They found in the original trials that led to the approval, coercion, mandates of the vaccine, one was more likely to suffer a serious adverse event, disability, hospitalization, life-changing event, than one was to be hospitalized with COVID, when everything is corrected for, during the original Wuhan strain. And that rate was about at least 1 in 800 in the first 2 months. Likely an underestimate, by the way, because it doesn't take into consideration what happens after a few months. But this is at the beginning. All right, and of course, this is another interesting thing. The World Health Organization at the very beginning actually endorsed a list of potential serious adverse events that could happen because of this vaccine based upon other vaccine data, the technology that was being used, animal studies, and even COVID itself. And look at that list. It's exactly the kind of things we are seeing in the community right now. All I'm saying is, I'm not saying all these problems that people are having are the vaccine, but it needs to be part of the differential diagnosis when doctors are seeing patients with these conditions. At the moment, they are not even accepting, many doctors, that even these things exist or it could be the vaccine. It's completely being ignored, and this isn't right, okay? And we know there are different mechanisms that have been explained about the spike protein and lipid nanoparticles, and what was supposed to just stay in the arm and generate an immune response is causing problems throughout the body potentially, and could stay in the body and cause these issues for about 4 months as well. Now, what about cardiac arrests? We've had 14,000 yet to be unexplained cardiac arrests in 2021 versus 2020. We can see that, and again, that certainly seems to coincide with the vaccine rollout. In Israel, researchers, I spoke to one of them, found there was a 25% increase in heart attacks and cardiac arrests in people aged between 16 and 39 that they said was associated with the vaccine but not associated with COVID. This was published in Nature Scientific Reports. It's peer-reviewed. The data, Florida Surgeon General recently put out that their original analysis from the rollout of the vaccine at the very beginning in 2021 basically found that there was a significantly increased risk, again, of cardiac arrests in people aged between 18 and 39. So they've said that we should stop it in under 40-year-olds. The British Heart Foundation recently, you remember this? You may remember this. I think it was only last week. So we've got 30,000 excess deaths specifically related to coronary artery disease. They're unexplained. They've suggested it could be because of NHS waiting, although the College of Emergency Medicine said about 5,000 deaths could be just purely because of delays. But again, a lot of this is unexplained. They're speculating. Again, the vaccine hasn't been mentioned. But what's interesting is they have explicitly said that these excess deaths now are not related to COVID. So there's no protection from infection now, clearly. Initial protection from the ancestral variant at best was 1 in 119. No reduction in COVID mortality and all-cause mortality from the randomized control trials. We know, and the highest quality level of data, 1 in 800 probably in terms of a serious adverse event. Now, let's give some perspective here. We have pulled vaccines in the past for much less. Swine flu vaccine 1976 caused Guillain-Barré syndrome in 1 in 100,000 people. Rotavirus vaccine 2006 caused a form of bowel obstruction in kids affecting 1 in 10,000. That was enough to pull the vaccine. We have got the highest level quality of data saying that that this is 1 in 800 at least. It shouldn't in normal circumstances even been debated. This vaccine needs to be suspended completely pending an inquiry, right? Now, what else do we know? Natural immunity is very protective, okay? And if you have natural immunity, I think it is just beyond comprehension. Why are we vaccinating people that have already had COVID? It is just unbelievable. And we know, what's worse, you are more likely to suffer a significant side effect. Okay, unprecedented harms from the yellow card scheme. I won't go there. Because I think people know about that. And again, that's probably at least 1 in 1,000. This is thought to be serious adverse events traditionally are thought to underestimate by tenfold the serious adverse events. It's likely much higher, to be honest. It's likely much, much higher. Okay, I'm going to take a step back here because I want people to understand the causes of the causes. We're going to finish up certainly in the next 5-10 minutes. So I'm going to try and rush through this and get through this properly. Okay. We're talking about here, ultimately, we need to move forward productively. We've got information on the vaccine. We need to understand the bigger drivers that are causing this problem across the world in terms of health and what's really damaging democracy as well. So this health impact pyramid tells us that socioeconomic factors are the biggest impact on population health. And now how does that get driven? These factors are being driven essentially by the biopsychosocial model. So essentially a combination of chronic psychological stress, and how that interacts with environment and diet and lifestyle is ultimately the root cause of many of the problems that drive disease. We know if people have there's epigenetic studies, we know that, for example, mothers with disabled children will, at the most stress levels, can live on average 20 years less in terms of their life expectancy, okay? And we know the inequality that's going on in society is a big driver of the fact that we have many premature deaths, because we've got to think about the whole healthcare system as well. And the reason why inequality is a driver of poor health outcomes is something called status anxiety. So in societies where you have a bigger gap between the rich and the poor, everybody is more stressed because we are comparing ourselves to each other based upon often, status and materialism. The other thing that's really important to understand, and this is, by the way, I'm getting to corporate drivers in a second behind this, is a poor quality or stressful job can be more damaging to health than being unemployed. So if you're in a low-paid, high-demand, low-control job, it's effectively a death sentence. So we need to sort that out as well, okay? Now, who is behind all of this? What are the drivers behind it? The global drivers really are what we call the commercial determinants of health, big corporations. We describe this as strategies and approaches, and this applies to big pharma, adopted by the private sector to promote products and choices that are detrimental to health. Now, how do big pharma, and let's talk about the COVID vaccine again, how have they exerted all this power to the point now where even though we've got clear, unequivocal data, there is willful blindness going on? What's actually happening? So they can do this through a number of mechanisms. We have capturing the narrative. We have capturing politicians. We also have this other aspect, which is they exert this they're able to exert power in a way to avert conflict and keep conflict latent, hidden, okay? That means conflict between the interests of the powerful and those over whom power is exerted. Doctors, patients, and the public don't know what's really happening, and they don't even know that they don't know. Now, political environment, lobbying, we know that. I've spoken to many politicians, people that genuinely think the information they're getting from lobbying and from lobbyists in drug industry is correct, not hearing the other side, and ultimately it's erroneous. Preference shaping, capture of the media. A lot of people, unfortunately, get their opinion from the media. Philanthropic organizations, the Bill and Melinda Gates Foundation, for example, huge influence. Now, many people don't know the Bill and Melinda Gates Foundation are heavily invested stocks in drug companies, McDonald's and Coca-Cola. And Bill Gates thinks he's going to solve population health. He's not paying any attention to non-communicable diseases. The knowledge environment, funding of medical research, medical education. Legal environment, limited liability, and threat of litigation and preemption if people then try and raise alarms about what the drug industry are doing. And of course, extra-legal environment is opposition, fragmentation, and deplatforming. We've seen it on social media, haven't we? We've seen this deplatforming going on, that even through social media, it's not easy to get this information out. And that's why we need to make sure that tackling corporate power becomes a public health priority. Now, let's talk about scientific fraud, right? So, the Vioxx scandal, Merck were fined in 2011 almost £1 billion for fraud in relation to their drug Vioxx, an anti-inflammatory drug that was marketed on the basis that it thought it was supposed to be better than ibuprofen because it caused less stomach problems, but ultimately it was found to cause increase in heart attacks, and it was estimated it probably killed 40 to 60,000 Americans. And in this conversation with John Abramson and Joe Rogan, and John Abramson's a colleague, I know John well, he talks about the fact that during the litigation, internal emails revealed that the chief scientist of Merck knew about, when it was being rolled out, about the problem that was going to happen. And essentially, words to the effect were, in the email, it's a shame about the cardiovascular effects, but the drug will do well and we will do well. What do you call that kind of behavior? Right? Now, Dr. Robert Hare, forensic psychologist, an expert on psychopathy, involved in the original diagnosis of what the criteria is for psychopath, says that these corporations, identities, I'm not naming individuals here, okay? You can make your own opinion on that yourself. But I'm talking about the entity that is a big corporation, that is big pharma, functions like a psychopathic entity in what it does. That is, for me, and I could be wrong, my hypothesis to what is going on right now and continue to go on is rooted in this psychopathic determinants of health. okay? Incapacity, callous unconcern for the feelings of others, reckless disregard for the safety of others, deceitfulness, repeated lying, and conning others for profit. They have had increasing unchecked power over the last few decades because of economic policies, and now we are feeling the full brunt of it, right? So Tony Fauci said, trust the science, which, by the way, is one of the most unscientific statements because science evolves, okay? He says, trust the science, but in effect, what's been happening is, this may sound controversial, we have been unwittingly trusting the psychopath. And what's going to happen when you trust a psychopath? When a psychopath, again, he has so much control and influence on your life, what is it going to do to you mentally and physically? What kind of culture is it going to create? We've also got the fact that Facebook partnered with Merck, Vioxx scandal, to tackle vaccine hesitancy and misinformation on there. These are the people that are the so-called fact checkers. This is ultimately who they're being controlled by. And of course, in the NHS, all of these system failure problems that fail to tackle the food industry, pharma, are creating this medical misinformation, damaging people's mental and physical health. I myself have suffered personally. I've lost all my family members prematurely. My brother when I was young, that wasn't to do with NHS failures, but to lose both my parents in the space of 3 years was devastating for me. And you know, they were both linked to failures within the NHS, within the system. My mother, because of the fact that we are so overwhelmed with work, because we haven't tackled all the prevention side, because there's too much medicine, essentially for 2 hours went into heart failure before she got treatment, was essentially drowning. She suffered unnecessarily. She was also had problems with obesity and linked to food addiction. So again, that was a big driver of her poor health, died at 68. My father, as many of you know, had a delay. I was on a call to him when he had chest pain. During that call, I FaceTimed him. He had a cardiac arrest. People were there. They were doing CPR on him. I said, he's going to survive because it was witnessed. I know that ambulance crews get here in 8 minutes. It took 30 minutes, right? And he didn't survive. And I had to FaceTime him, and I had to tell them to stop resuscitating him when I saw the flat line on his monitor. And ultimately, I realized with the post-mortem findings that the primary cause, unfortunately, of my father's death was a vaccine. So I want to do this in a rational way, devoid of emotion. But for me, I'm also his only advocate now. Nobody else can be his advocate. What do we do? How do we... Okay, so we've identified the problem. What can we do about it, right? So there is a model called the triangle that moves a mountain. We've got to move a mountain. How do we do that? We need to make sure we've got clear, relevant, concrete knowledge in a way that can be disseminated and understandable to the public with killer key facts. We have the social movement. Now, I know it's not been easy. We haven't broken mainstream media here. Certainly what I've done with this paper, I've managed to get international coverage, but we haven't broken mainstream media in the UK, and we need to do that. And politicians, as much as we may not, respect them as much as we should, I still have most power to actually exert change. And there are a lot of good politicians out there, but they need to be given the information in a way that but it needs to be disseminated ultimately through the media, okay? Now, how do we do that? Well, there are ways, there are key bits of information for public health advocacy to make these changes happen, right? One of the things that's important to understand is that careers are often built on a lifetime commitment to a particular phase of evidence, but if the evidence changes, as I have had to change with evidence that became familiar to me, having had the vaccine, having tackled vaccine hesitancy, that it's absolutely crucial for the integrity of public health that we acknowledge the facts have changed, and accordingly we have changed our minds too. Now, unfortunately, and this is a challenge, media attention on a public health issue is often more effective than private advocacy in winning policy change. The advocacy must be evidence-based, clear and concrete. Sunlight is a very powerful, potent disinfectant for malodorous health policy. And there is no more powerful sunlight than major media attention. So we need to keep pushing there. However, we can still use social media. That movement is growing. I've seen a shift. We need to make sure we keep moving forward and keep pushing this on social media as much as we can. And we have to grow our rhinoceros hide. These are people on the front line. These are all of us, actually, right? Because as soon as your work threatens an industry or an ideological cabal, you will be attacked, sometimes unrelentingly and viciously. right? And I have experienced that anecdotally. I'm not going to give you lots of anecdotes on that, but I remember when I helped Tom Watson, the former deputy leader of the Labour Party, lose 100 pounds through a very simple diet of just eating real food and avoiding ultra-processed stuff, and wrote a book about it. The chief executive of Public Health England tried to stop me speaking at a hospital, tried to get people who'd endorsed my book, including Andy Burnham, the chair of the Medical Royal Colleges, basically saying that this wasn't in keeping with the NHS Eat Well plate, which, by the way, has junk food on there. And when I met the chief nutritionist of Public Health England a while back, Alison Tedston, I had a conversation about this and said, Alison, why, okay, we can argue the science about diet. Why have you got junk food on the Eat Well plate saying eat, less often in small amounts? Why is it even on there? Her answer to me, Aseem, you've got to understand one of the biggest contributors to our economy is the food industry, right? What? This is a culture. This is a cultural problem that we've got here. And then about a week after I spoke in Parliament about reversing type 2 diabetes when I met Hancock a few years ago, the Mail on Sunday then did a hatchet job on me, Zoe Harcombe, Malcolm Kendrick GP, front page featured, basically said a place belongs in hell for doctors who claim, doctors like me essentially, who were promoting shared decision-making, not saying statins don't work, cholesterol-lowering drug, okay? And interestingly, guess who was part of that conversation? Matt Hancock was quoted saying there is no place for people like this in our NHS, right? Now, I asked Matt, I said, hold on a minute, Matt, what's going on here? Oh, Aseem, I'm so sorry, I didn't realize it was you. Direct messages with Matt Hancock on that. Right, but there is some good that comes from it. Listen, it's hard to do this stuff, but for me, one of the most personal, how shall I put it, what has given me great satisfaction is doing what I could when the NHS vaccine mandate came out, and I was on Sky News, BBC, LBC, with Majid Nawaz, GB News, is to help get this NHS vaccine mandate overturned. And I want to thank those doctors and nurses that stood their ground. And I remember beforehand, I was having conversations with the chair of the BMA, I was getting information to Sajid Javid, and I knew they were going to overturn it. Now, it may be because they realized many of these doctors and nurses were not going to budge, and we would have a big health crisis, but I'm glad that you stood your ground, so thank you for that. Right, we're about to finish. What do we do moving forward? Okay, although the pharmaceutical industry plays an important role in developing all new drugs, they should play no role in testing them, and they certainly shouldn't be allowed to hide onto the raw data. No more. Enough of their bullshit. I'm sorry, enough of their bullshit. All results of all trials in humans must be made publicly available. Regulators such as the FDA and the MHRA should not get any money from the drug industry. Enough. This is not democratic. I don't think you'll find a single person, member of the public, if you went and asked them, are you happy that the regulator deciding on what drugs are safe and effective are getting most of their money from the drug industry? This is not democratic. Politicians will need to understand that, right? They need to be aware of that information. So, where are we now? Right. Basically, this vaccine needs to be suspended. We know that until all the raw data is released for independent scrutiny. What can you do? There's a big social media movement. Things are progressing. I think we need to keep capitalizing on that. Certainly, Twitter isn't doing any bans at the moment on this. So what I'm suggesting you can do, and you can decide for yourself, I'm going to do this later on tonight or tomorrow morning. I'm going to copy in Steve Barclay, the Secretary of State for Health. Please take a screenshot of this if you want, and do your own tweet and video. Tag me, I will retweet it, I'll quote tweet it, and you basically say, I will say, for example, my name is Dr. Aseem Malhotra, consultant cardiologist, and I call on the Secretary of State for Health, Steve Barclay, to suspend the mRNA jabs now until the raw data is released for independent analysis. If all of you do videos on that, it takes 15 seconds, and share it on Twitter or wherever social media, I and other people will be very happy to retweet it. Let's get this. Let's just keep getting this message out there. Let's keep pushing. Although I'm speaking in a personal capacity today, something else you can do is you can come, I'm part of a charity called the Public Health Collaboration, and made up of doctors, nurses, patients, nutritionists, pharmacists. We are here to try and fix the NHS. We're funded by the public for the public. We are working on a document to try and get all of this together for next year, and please go to our website, join up. We're going to do a conference in May. We're going to try, and we need all of your help. And what do we need to do otherwise? Well, we need to think about how do we overturn the corporation. We need to disconnect our public health research, our medical research from these powerful companies. We need to disconnect that. We need to redesign the corporation. Abraham Lincoln was probably quite prophetic. He said, "I see in the near future a crisis approaching that unnerves me and causes me to tremble for the safety of my country. Corporations have been enthroned, and an era of corruption in high places will follow, and the money power of the country will endeavor to prolong its reign by working upon the prejudice of the people until all the wealth is aggregated in a few hands and the republic is destroyed." The late Robert Kennedy said something else. We also need to think about ourselves and the culture that we have inherited and how we need to go back to something more basic about values and spirituality. Robert Kennedy, "The gross national product does not allow for the health of our children, the quality of their education, or the joy of their play. It does not include the beauty of our poetry, or the intelligence of our public debate, or the integrity of our public officials. It measures neither our wit nor our courage, neither our wisdom nor our learning, neither our compassion nor our devotion to our country. It measures everything, in short, which makes life worthwhile." And to do that, it means we also have to act in a virtuous way. And of all the virtues that are important for us to really beat this psychopathic corporate tyranny that unfortunately is causing so many problems around the world, we have to come back to the basics of acting virtuously. And that also means the most important of those is courage. It's the most important of all virtues because without courage, you can't practice any other virtue consistently. So we need a bit more courage. You know, Mahatma Gandhi is one of my inspirations. It's time to remind ourselves that it's health that is the greatest wealth, not pieces of gold and silver. It's time to rise up against this organization of misery. Harvey Milk said, "Remember, rights are only won by those who make their voices heard." It's time for us to make our voices heard. It's not easy. It's challenging. It's easy to get apathetic. But as Martin Luther King said, if you can't drive, you run. If you can't run, you walk. If you can't walk, you crawl. But keep moving forward. So let's do this. Let's keep going. Thank you.